So welcome back, everybody. I hope you got to spend some time chatting with each other and visiting all of our sponsors and enjoying some dessert. So each year at our education night, we like to share the stories and voices of the patients and families at our clinic through a panel discussion. This is consistently reported to be the highlight of the event, and we often choose topics for the panel based on feedback from all of you. Over the last few years, we've had interest from many of you in the topics of both lung transplant and of pregnancy and childbirth. In developing the agenda for tonight and considering who might be able and willing to share their experiences of a topic like this, we realized that we have a very unique opportunity. Meg and Kate are sisters who both have CF and who both undergone enormous changes this past year. Meg gave birth to her first child, and Kate had a double lung transplant, and they have generously agreed to join a panel discussion with Dr. Lori Leclair to talk about what this was like for them and what their lives are like now. So this panel discussion will be moderated by Tara McCuin, who is a psychologist at UVM Medical Center and a member of the CF Care team. Tara will open the discussion up to accept questions from the audience at the end. So I'd like you to welcome, please, Tara, Lori, Meg, and Kate to the stage.
So thank you both for being here tonight, and thank you, Lori. I'll probably start off with if you both would just be willing to give us a brief introduction to you here for us tonight, and then we'll get into each of your stories.
Can you hear me? No? Better? So I'm Meg Quiet. I grew up in Bristol, Vermont. I am the older of the two of us. I'm just turned 30. I live in Bristol with my husband Josh and my daughter Madison, who just turned 1 a couple weeks ago. And yeah, that's pretty much it.
I'm Kate. I'm 28 years old, been living with CF, obviously all those years. I had my double lung transplant about 1.5 years ago, and I just had my 28th birthday on April 19th.
So again, thank you both for being here. Meg, I was wondering if you'd be willing to kick us off and just kind of take us through your journey, starting with the process of getting pregnant, and then all the way through to being a new mom, and kind of what that looked like for you and the challenges that might have been involved.
Okay, so my husband and I decided several years ago that we wanted to have a baby, and we tried for about 3 years to get pregnant on our own, and with no success. So we had kind of put it off for a long time, going to see somebody about why it hadn't happened yet. And eventually we did. I was obviously nervous that they were going to say something was wrong with me because I was the one with the chronic health issue. So we went and we did some pretty extensive fertility testing, and they actually found that we were both completely normal and healthy. So we ended up, they ended up basically saying that probably because of the increased secretions that people with CF have, that probably that was just another barrier to us getting pregnant. So we actually started off with IUI treatment, which is intrauterine insemination, and were successful the second time that we tried it. So it was pretty cool. It happened pretty quickly once we figured out what was going on. It was much cheaper, much much more cost effective, much less invasive than IVF, which we were really thankful for. And like I said, very, very simple, took minutes to perform, so that was great. We started off even before that, like, I don't know, right after we got married, my husband was tested to see if he was a carrier of cystic fibrosis, and he wasn't a carrier of the top, however many the Mayo Clinic tests for, I'm not sure, it's some 100 and something, I don't know. And he wasn't a carrier, so we were pretty comfortable moving forward with the pregnancy, just knowing that he didn't carry any of those top mutations of CF. It was covered by insurance. I know that's probably a question that people have, but because I have CF, insurance covered testing him as well. Challenges during pregnancy, I would say first and foremost would be gaining and maintaining weight. Mostly because I've always been a pretty conscious person about what I eat and keeping up with exercise and all that stuff, and don't like to eat a lot of empty calories. I like to eat pretty healthy, so eating enough to maintain and then gain weight as you need to during pregnancy. I think the first 3 or 4 months I didn't gain any weight, and then we finally figured it out, and I was able to gain some weight. I would say another challenge would be once I got further along in the pregnancy and my belly got bigger, taking deeper breaths and being able to actually perform my PFTs became more challenging. And then being more short of breath just because I didn't have as much space to inflate as I normally would. And then, as probably every mom can attest to, the baby kicking you in the ribs and all that stuff doesn't feel great. That's probably just a normal challenge. And then another thing that was asked of me to speak about was changing or switching medications. So when we had decided that we were going to try to get pregnant, I came off of just one medication, and everything else was safe to take, and I came off of azithromycin, and I came off of that as a personal choice, not as a recommendation for not taking it when you're pregnant. And otherwise, all the other medications that I took were safe. Anything else you can think of?
Yeah, I was also curious in terms of your OB care. Did you feel like your OB was knowledgeable about CF, and throughout your getting pregnant and your pregnancy that you felt comfortable with them in that round, and how did they interface kind of with your treatment team at UVM? So
the good thing about being at UVM and seeing the high-risk doctors at UVM, because I was seen by the high-risk specialty OB care team, was that if they didn't know something, it felt like they were very willing to communicate with the pulmonary side of things, so that everything that we did, I felt like was pretty seamless with regard to how is this going to affect your baby and how is this going to affect your CF. So I felt like they did a good job communicating, and they weren't afraid to admit if they weren't sure about something, and they were willing to pick up the phone, I feel like, most of the time and give you a call. I saw them a lot more frequently than I think my friends that weren't high-risk pregnancies, and then also saw Dr. Leclair and her team more frequently than every 3 months, just because we were monitoring everything. But I felt like they were pretty knowledgeable. I still feel like there's not a ton of knowledge of CF patients having kids. So some stuff they were just like for example, gestational diabetes. So I don't currently have CF-related diabetes, but when I was pregnant, I did my OGTT earlier in pregnancy than a normal woman would do it, and I fell into a criteria, sort of gestational diabetes. So I monitored my blood sugars while I was pregnant and watched what I ate, and I didn't have to have any insulin or anything, but I was checking my blood sugars 4 times a day, or after meals or whatever. And that felt like a very gray area. And maybe Dr. Leclair can speak more to that, but that was sort of like well, it's sort of gestational diabetes, but we're not really sure. So that was probably the only thing I felt like wasn't, yeah.
And Dr. Leclair, can you speak to that a little? How you interface with kind of OB teams and what tends to come up?
Yeah, so just to speak generally, I should have looked at this before, but it's actually sort of common for adults with CF to have children, men and women, and we have probably 1 or 2 babies a year almost. So it's kind of, it's a common rare event, if you know what I mean, because CF is it's a common rare disease. So our high risk group has some experience, but our center's not big enough that they're caring for 10 or 20 pregnant CF women routinely. So that's a bit of a struggle in areas where our sort of medical opinion really overlaps, and I think diabetes is one. And so the obstetricians pay very close attention to diabetic pregnant ladies, particularly because high blood sugars are bad and for fetal development. So it's a very big deal for them. And they have all their criteria that they use in the non-CF patient. And they have a joint clinic with endocrine and other stuff. So, then we show up with our diabetics, whom we are equally territorial over, or our patients. And, and the rules are a little different. But to Meg's point, unless it's a huge geographical hardship, we really strongly encourage our patients to get their obstetrical care here through the high-risk group, because we know each other, we can easily communicate if there's an issue or a problem. So I was laughing about you bringing up diabetes, because in my head I was like, I wonder if she'll say something about diabetes. But yeah, and so the screening of the glucose tests, the timing is different if you have CF and are pregnant than usual gestational diabetes. It's it's in our care guidelines, and so we, in Meg's case, just offered those up and had a conversation, and ended up in a place where everybody felt like their needs were being met, and most importantly, what you would want and hope for, I think, from the patient side is that you have docs who really just want to do absolutely right by you, and so. Yeah, I think that happens fairly routinely. And then the other stuff, it's very synergistic, because I don't know a lot about pregnant ladies, but I know a lot about CF patients, and they don't know much about CF patients, but they know a lot about pregnant ladies. So, we can work together nicely in that way.
And I felt too, with regard to the communication between the 2 clinics, that if they were very conscious of the fact that I cared very much about the baby that I was carrying, because it was very important and it was very precious to me. And I felt like CF Clinic was very respectful of that. And I felt like they also, at the OB, knew that taking care of myself and lung function and being a healthy CF patient was also equally as important to me. And I felt like everybody was super respectful of the fact that both of those things needed to work really well for me. And I'm very thankful that they were both so gracious to be supportive of both ends of both things.
Thank you. And now, being a new mom, how is that going with balancing taking care of your CF?
So and as any new mom can probably attest to, it is very challenging just to take care of yourself and your child on a daily basis, especially as a new mom. So add in that you have an hour in the morning and an hour in the evening, and then maybe a middle of the day treatment that you have to do, and it makes things a little bit more complicated. It makes your day a little bit longer, it makes your day a little bit busier, but I have found a good way to manage it. My daughter is so used to being on my lap while I do my vest, and we read stories while I'm doing my vest, so she's you know, it's like she's part of my therapy. We sit there, we read books, and she shakes with me, and she's not bothered by it, and she hasn't been bothered by it since she was an infant, so that's good. She likes to try to put my nebulizers in her mouth, which we're still working on her not doing, but otherwise, not a lot has changed for me, and I'm sure Dr. Leclair will agree that that probably is because I'm type A, have to get everything done. That's just the kind of person I am, so if it means I have to get up an hour earlier or stay up an hour later, it gets done, because that's what it needs to get done, and that's, you have to take care of yourself before you can take care of anybody else. So that's been like my primary mantra, is like, you have to take care of yourself before you can take care of anybody else, and if you're healthy, then you can take care of. So that's pretty much it.
Sounds like a good strategy. And Dr. Leclair, I didn't know if you could speak to, I think occasionally patients have questions, and I don't know that you've had an exacerbation or had to be hospitalized, but how the hospital accommodates nursing moms, or kind of what changes medically if there is an exacerbation for a new mom.
Yeah, so I think whether you're pregnant, and you touched on this a little bit, Meg, in terms of medical therapies or nursing, you know, you have to always consider the, you know, the health of the patient. And I'm always, full disclosure, I always, you know, tell my patients, I'm in your corner. So, you know, I'm sort of anchored in advice that I think is going to be best for you medically. We'll pull in other people who will consider the other side. So if you're pregnant, the obstetrician, is this med going to be okay, et cetera. Or the pediatrician if you're nursing. But I think Meg put it the best, that the mom's got to be healthy to help the baby. And I think that, to a certain extent, is as true when you're pregnant as it is after you're delivered. So we generally don't have to make big adjustments. If a nursing mom, you know, may opt not to, you know, feed the breast milk to the baby at the time that they're receiving certain antibiotics or so forth. Okay. Notice the pulmonologist still talking while the patient's choking. That should be a red flag right there. So the mom's health is critically important, I think, in many regards, and usually you can navigate, and there's other options or other strategies, you know, in terms of medication exposure if the mom is sick and needs it. In terms of accommodations at the hospital, I think we're at a time in medicine where patient-centered care is becoming, you know, on everybody's radar. It's always been the CF model, so I'm glad to see it spreading through medicine. And, you know, in my experience recently, new moms haven't necessarily wanted their children to stay with them, for example, in the hospital. But, you know, that's something that could be accommodated if that was what the family desired. And I think I'll back up 1 second and just say, in general, I think the CF team feels, you know, that we want for the patient what the patient wants for themselves. And so, you know, I don't endorse bungee jumping or riding motorcycles. Aside from that, those are the two caveats. But short of that, you know, whatever it is you want in your life, if it's to have a child, then we'll find a path forward so that can happen. Because, you know, that's part of the job, you know, that we have, and that may be investigating insurance options, getting access to childcare support so that you can get your treatments done, et cetera, et cetera. And we've done any and all of that for our patients over the years, because I do worry about what happens after you deliver. I'm the mother of a 3- and 7-year-old, and it's fresh enough in my mind how incredibly difficult caring for young children is without a chronic illness. So that's the piece that I think the CF team is actually super, super focused on. And it's one of the reasons why, the guidelines recommend that pregnant, women come monthly to clinic. And I actually like them coming monthly to clinic after the delivery of the baby as well, if not more than that, depending, because that's when we can see a lot of weight loss and exacerbations, because, every mom in the room can say that you're exhausted and just strung out, and so that's a really vulnerable time when the obstetricians have faded out a bit.
And I will say too, to speak to that, when I was pregnant, I did get sick to the point where I did have to be admitted to the hospital because the oral antibiotics that I needed to treat the bugs that I have were not safe for pregnancy, so IV therapy was the safest route for that. And that was, I think I was in for like 10 days or 10 or 11 days or something. And then we ended up stopping because I got a blood clot in my arm, but which is a complication of CF and pregnancy. So, and then as far as nursing is concerned, there have been a couple times that I've gone on antibiotics while I have been nursing, oral ones, and they've been totally safe. My pediatrician and the people over at the pulmonary clinic talked with each other, and they came up with a good solution. So they're definitely good about the communication and making sure that you're comfortable with what you're doing.
Thank you, and thank you for sharing. Kate, in the interest of time, would jump to you. Not only are you a new aunt, but you recently had a double lung transplant. I was hoping you could kind of speak to us about your journey, starting with making the transplant list all the way through to post-recovery.
It'd be a long story. If you have received the newsletter that they were talking about earlier, I also was asked to write a piece in that, so if I've missed anything, you can read that and kind of fill in the blanks yourself. So it all kind of started, 2013-ish. I spent a lot of time in the ICU, and that was kind of when I started getting my testing done to get on the transplant list. I had a really bad exacerbation. I spent like 6 or 7 weeks in the ICU up at UVM, and I had been seen in Boston for probably a few months before that, and was starting the process because I got the referral after one of my 2-week stints just on M6 at UVM, and they kind of mentioned it, and we started the ball rolling, went down to Boston, met their team down there, and then came back up and was seeing them every 3 or so months, so kind of like on the CF clinic side of things, every 3 months, they just kind of check in to see where you're at. And it was when I was admitted to the ICU for so long, and I was so sick that they just let us start testing up here at UVM. And so it was a lot of testing to undergo while I was sick in the hospital. But I think there were probably a week full of mornings where I would be wheeled off for a test, or they'd come in and say, oh, we have to do this test now. And it's just kind of, you go with whatever they say that they need, and you just let them do it. Otherwise, they don't have the information they need to make the decisions that they need to make as far as putting on the transplant list. Probably December of 2014, I got the call saying that I was on the transplant list, and that was after all the testing and going down to Boston and being seen. So I was on quite a bit of oxygen, not just for exercise anymore, because originally it was just for exercise, and then once I went home after my really long stint in the hospital, that it became an all-the-time thing at night with my BiPAP mask, all that good stuff. So home and just kind of playing it by ear, keeping my phone on me all the time. In and out of the hospital for the next year or so. I remember I got out of the hospital on a Friday after, 4 or 5 weeks in just the regular unit. And it was a Tuesday, so 4 days after I'd gotten out of the hospital that I got a phone call from Mass General, and they were, checking in on me, I thought, and asking me all these questions. And then I kind of realized something was different when they asked me if I had eaten anything that morning or during the day, and I was like, I'm actually eating right now. And they're like, well, maybe you should stop because we have a few things to consider, but we do have a possible donor for you. So, just hang on for the next half an hour and we'll give you a call back. And I was like, oh, okay. So I was home and my mom was actually at work. My stepdad was at work. My sister was up at work at Rice. And so I ended up calling my dad and he didn't answer his phone right away. So I started panicking. But he called me back and I, basically said, Dad, look, they're calling me back in a half an hour. We're gonna probably have to go to Boston. And I had texted Mom and she knew what was going on. I texted Megan and my 2 cousins. So they all knew what was going on. And half an hour later they said, yep, make your way down. And don't rush, don't speed, don't injure yourself on the way down, but get down here. So we got down there. I got admitted, they put an IV in, and they were doing all of their normal. They test frequently just to make sure things haven't changed, so they drew a bunch of blood, and we just kind of sat there waiting all night to kind of hear the news, and I don't remember, 1 or 2 o'clock in the morning, they told us that we were going to be going to surgery, that it was a go, and that I was probably going around 5:30, 6 o'clock in the morning. Well, I remember going down at like 6 o'clock in the morning. So, and we started getting prepped for surgery 4 o'clock in the morning. My mom's giving me signals from the table over there. I don't remember the times, it's all kind of a whirlwind.
We were told to be back at 5, and 5 was too late.
Yeah. My sister and one of her best friends and my cousin all got a hotel room, and they had to rush in the next morning, but on minimal sleep because they were at the hospital for a long time, calling to try to find a place to stay because apparently there was an event going on and there were no hotels available. So, and my hospital room was full, so I had they brought in a chair and a bed, an extra bed, and then we had the other hospital bed, and they were all full. So anyway, 4 o'clock in the morning, wheeled down to pre-op and went into surgery, obviously very nervous, crying and smiling and laughing, and everybody was really great. They were really supportive, and I just remember going to sleep and then waking up in the ICU, I think 2 days, a day and a half later, a day later. So my transplant was on the 28th, and I woke up on 29th. Okay, I was still pretty out of it. Was it the 30th? Anyways, I woke up with them extubating me, which is a very unpleasant experience. And I could hear people outside my room, my fishbowl room, because ICU, it was a double door ICU, so you come in one, get your stuff on, and then come in the other door. So I could hear people outside that while I was half awake and they were pulling my tube. And I spent probably a week and a half in the ICU, which was a little bit longer than they normally have you stay in, just because I had a new bacteria from my donor. And there were a couple other things that they wanted to just make sure was stable before I got moved down to the step-down unit. And then I spent probably a week or maybe less in the step-down unit, and then we were able to find an apartment in Boston, like a 5 or 10 minute walk. 5-minute walk if you haven't just had a lung transplant, but like a 10 or 15-minute walk if you just have had one. So we rented that. We were there for a couple months because I was having a couple appointments, at least 2 a week with the transplant team. And then I started physical therapy down there, and I continued it up here. And I got home in January. I think my first trip back was for Christmas, and they let me stay home for like a week and a half for 2 weeks, and then we went back down for one last appointment, and we moved out. We were done by the 9th of January. So, and I moved home and just recovering, PT, stuff like that, getting used to my regular routine, seeing friends, seeing family again on a routine basis, not just when they were able to make the trip down to Boston. And then just, it's been upwards ever since, and I don't think my lung function has been this good in, God, since I've seen you. I think it's in the 90s, or close to the 90s now, and I don't even remember what it was when I started seeing Dr. Leclair at the adult CF clinic. I don't even know when I was seeing Dr. Lahiri, if it was even that high, so.
Quite a journey you've been on, clearly. And I was struck by, throughout your story, talking about your family members and the support being there. And I didn't know if you or Meg could kind of speak to that, what that looked like, how important that was kind of throughout the process.
Yeah, I mean, I think it was, certainly wouldn't have gotten through it without my family. My mom took time off from work. So she was down in Boston with me all the time. She'd come home on the weekends, and my dad would come down. My stepdad was there all the time. My sister was there when she could be, although she was quite large and pregnant. But when she wasn't too tired to come down because of the baby, she came down and spent some weekends with me. My cousins came down. They were always there for me and constantly helping me, and yeah.
I think the biggest thing from the family standpoint is just continuing to encourage Caitlin, because I think one of the things that she said to me that still sticks out in my mind is, she initially afterwards, did I make the right choice? Did I do the right thing? Should I have done this? And absolutely, 100% yes. And I think for her, the challenge was, it's not so much that she had to do treatments and it was new stuff. And she was like, how am I ever going to remember to take these medicines at these times and to do this when I'm supposed to do this? And I finally just said to her at one point, I was like, Caitlin, it's no different than what we do right now with having CF. It's just, it's new, and you just have to get used to it. And in no time, you're going to be doing it just like we do all of our regular meds and all of our regular treatments. And look at her, she is. So it's...
So it sounds like family support really, really important all around. And Caitlin, I was wondering if you could speak to what is different in life now, kind of since the transplant, in terms of treatments and medication, and kind of across the board.
Yeah, so it's still a whole lot of medication, which, whatever. I mean, we're on a whole lot of medications as a CF patient. For a while, I do have CF-related diabetes, so that was a challenge at first because you're on a whole lot of steroids. So you're, checking your finger sticks all the time, taking loads of insulin, especially right after transplant, so when you're still in the hospital. But then until they've kind of weaned you down off of your steroids, you're still on pretty high amounts. So that's kind of a difference. Right now, I'm on just a regular dose of prednisone, and so handful of pills in the morning, handful of pills in the evening before bed. And a lot of times they'll discontinue your nebulizers. Occasionally you'll still have bacteria growing. Like I mentioned, I had some complications, so there was some bacteria in my lungs from the donor. So it was the bacteria that he had while he was still in the hospital. And we managed to clear most of that out before I went home, and then my bronchoscopies have been clear from the bacteria that he had after transplant. But then, everything's kind of interconnected. I had the Pseudomonas in my nose, so now that gets kind of pushed down into my lungs, but so far that's not been a huge problem. So I am still on the inhaled antibiotics. I'm, month on, month off, different antibiotics. On a lot of the same kind of medications, so I'm on the Azithro, some other antibiotics, some anti-rejection medications, still have the enzymes, but as far as treatment goes, there's no airway clearance. Occasionally, if I get sick, which luckily hasn't happened frequently since my transplant, I think I've had 1 or 2 bouts of feeling ill. The little acapella, which I'm sure a lot of you are familiar with, is what the transplant team usually recommends to just kind of do a couple times a day. But as far as that goes, that's, you know, no hooking up to a vest anymore, no 20 minutes sitting there shaking, which is nice. It's not waking up in the morning and doing an hour worth of treatments, but just being conscious of everything else that's around you. There's lifestyle changes as far as food that you can have, where you can have it, no more salad bar, no more buffet type food, because you never know who's been sneezing near it. Even if there is a sneeze guard, you never know who's been sneezing near it, so you kind of have to be conscious of that. Washing fruits and vegetables really well before you eat it, just because of, you know, where it's come from, pesticides, germs, stuff like that. And no, I haven't become a germaphobe since my transplant. I've just become more conscious about what's around me. So anybody that's sick, I try to avoid, which is difficult because you can't avoid sick people. I wear a mask whenever I go in the hospital now, just because that's generally where sick people like to, you know, hang out. It's just the place that they like to go. So that's kind of different. I never did before, but thinking of it, it probably wouldn't have been a bad idea. But yeah, mostly just lifestyle changes, and you take away quite a few of the treatments, but like I said, besides the nebs that I do every other month.
Dr. Leclair, I was wondering if you could speak to kind of in general, kind of from a physician's perspective, when you would begin having conversations about transplant with people, and what you see and communicate with people who are thinking of transplant about what might lead to better outcomes for them, kind of what the considerations are from your side when people are thinking of going through this.
Yeah, so I'll start by saying that, you know, transplant is definitely not for everyone. And for a variety of reasons, someone may decide, you know, early on that they're not interested. And you spoke to this a bit ago, because the autonomy piece, the being able to do what you want to do when you want to do it kind of thing, you really have to give that up. And I often say that we'll give that up together, because I'm going to have to stop doing what I want to do too. We'll be both taking our marching orders from someone else. And you know, and that, I think that's a jagged pill for a lot of people, and not worth it for some, frankly. There's sort of 2 issues when you think about timing for referral for lung transplant. One is kind of your absolute numbers of FEV1, and are you on oxygen, and do you have complications of low oxygen levels. And then the other is what's the rate of change. So, you know, people sometimes don't have great lung function, but they're super stable, and they're not really changing, and they're not emitted a lot, and you know, they're doing fine with the numbers they've got. Another type of individual may have just constantly declining lung function despite any and all aggressive interventions. And we do, so that I can't give you any exact criteria, except those 2 sort of general situations is when we would bring it up. And you know, usually would start with a conversation about, you know, we're putting it out there, it's a treatment option, okay? And I always say, I'm not saying this today or tomorrow, but I want to make sure that every door we want open for us is open. And if we want that door open, we need to plan for it. Because I don't know how it feels to be asked about if you want a referral to transplant. Maybe you could speak to that. How does that feel when someone says that to you?
It's kind of life-changing. I do remember the day that you came in and we talked about it. It was, yeah, I think it was in early 2014, like February. But it's like they tell you that, and then they just kind of walk out. Well, she's there to support me, but she also kind of, it was like, okay, I'm gonna leave you with that thought, and just think about it, and then just slinks out of the room.
I don't know.
And later they send in the psychologist, and you're like, I don't even know what just happened. But it's coming. As a CF patient, a lot of them are very healthy. I mean, my sister, she's 30, she's healthy, she goes in the hospital for 2 weeks at a time occasionally, and then you have situations where you have declining lung function, and it's not a fault of you. You've been doing your treatments all along, following everything that you're supposed to do, and it's just, it's the last treatment option. And like she said, it's not for everybody, and not everybody's a candidate, but...
So it's interesting to me that you can come up with the exact date.
I can't come up with a date, but
no, but that's
I
good.
remember, it was February.
Yeah.
And I remember, I remember when you came in and talked about that.
So when I walk in the room, I always think, this is sort of like the cancer word, right? That's like, as soon as the doc says cancer, nothing is going in after that. And so it's sort of the cancer equivalent in CF, I think. And I sort of know that, but it needs to be said. And, and it's a scary thing, and it's sort of, my view of it is sort of, it's kind of a doomsday thing when the doc says that, and, we don't bring it up when things are going well, for sure not, but again, it's a treatment option, and I want to get you what you want, and if this is what you want, this is what we have to do. And so it's sort of akin to pregnancy in that way. You want a baby, this is what we got to do. And so, so it's a process, and you highlighted the process. It's a lengthy process. It's a process of jumping through a lot of hoops. There's a lot of ups and downs. There's a lot of advocacy that has to go on, not only on the side of the family and the patient themselves, but the referring physicians. And we've got to be, I always joke, we got to be on our best behavior, you and me, our best behavior. Because we want that door open. And if we want that door open, and the reason we have to be on our best behavior is the behaviors are related to the outcomes. So they need adherent patients that are going to do what they're asked to when they're asked to. That's critical, because the transplant team's perspective is we've got a resource here, a valuable resource that's limited, that not everybody can have, and we want to have good outcomes. We want to pick the best people who are going to benefit the most from this very aggressive treatment. And so, if you keep that in your mind as you're going through the process and giving up some freedoms, like you didn't talk about the travel piece. What was the travel? You had travel restrictions, right? Didn't you, once you were enlisted?
Yeah, I couldn't go outside of 3 or 4 hours away from Boston. So it was like anywhere we wanted to go on vacation. And you don't really go on vacation when you're hauling your oxygen around. But I did it. But you can't be farther than 4 hours away. And we were kind of right on that limit of, if you get the call. And a lot of times, I don't want to say it's not urgent. Obviously, it is urgent for you to get to the center. But they were kind of like the chest is the last place where they go to get the organs out of. Because if they take the chest first, all the other organs are not available for donation anymore, because you're taking the blood supply away from them before you're harvesting them. I don't like that word either. But so they do that last, so while they're in surgery, it's almost like it's not a huge rush to get down there, so you might be able to kind of play with the limit a little bit, but they don't let you. So if I was any further north in Vermont, I would have probably had to move a little bit more south at least. Maybe even closer to or in Boston, because they're very strict about you being within 4 hours of the hospital, and the quicker you can get there for them, the better. Like I said, they have all the testing that they do prior, even if it is a dry run, which, I'm sure most of you are familiar with that word, is you get the call and the lungs, for whatever reason, are not a good match, or they got in there and they don't, they're not any better than what you have now. So they tell you no. doesn't look good, and unfortunately then they send you home, but you've had that trip under your belt. But still, to get down there within 4 hours or to your transplant center within 4 hours, they're pretty strict on that.
So, and just to maybe a couple words about the referral center. So for adults, there's 2 places in Boston, Mass General and the Brigham and Women's. And this center has used both, probably actually more the Brigham on average than MGH. And then in New York, it's Columbia. So we've run into a bit of trouble due to travel restrictions with patients who maybe are from 3 hours away in upstate New York, who get admitted here a lot but are listed in Columbia because we are way outside that 4-hour window. So that tends to be a less frequent issue. We tend to send even our upstate New York, unless they have insurance restrictions, to Boston because they are still often, especially if they're physically in our hospital, able to get to Boston within that window. But having to give up things like you can't decide to get on a plane and go somewhere or take a big road trip or whatever, that's just kind of part and parcel of the mindset of like, my goal and my fight is going to be directed towards getting this invasive treatment. And it takes a village to get through this process. And I think you guys are a great example of having a really nice village of people to help support the effort.
Hearing both of you kind of reflect on your journey to us, I was also kind of struck by and curious that now that you're on the other side of it, of if either of you and your thoughts around what you might have wished you had known going into it. So now that you've kind of gone into it and come out the other side, what would it have been nice to know or to kind of have supports or information available as you look back?
I think for me, the biggest point of contention anyways was the diabetes piece. Feeling like Dr. Leclair said, there are different guidelines for CF-related diabetes and gestational diabetes, and I felt like I was like trying to navigate the waters of both, and what is this from, or is it even? Because then when I went into labor, it wasn't even in the computer that I had gestational diabetes or that I had been being monitored for gestational diabetes. So it was very confusing whether or not I actually did or not. So I guess that piece was, for me anyways, the challenge.
I think the challenge for me, it would have been nice, obviously there's a lot of CF patients that have had double lung transplant that have made it through, but when you're in that moment and you're trying to recover, you don't feel like you're going to make it through. So it would have been nice to have somebody there to be like, no, that's normal. You are going to make it through. Like just some of the pains and some of like the other issues that crop up, and just to know that that was normal. You get some reassurance from the nurses and everybody when you're in the hospital on the transplant unit, but it's still like they are still kind of like, well, yeah, people have told me that that's normal, and the doctor says it's normal, so as long as you're comfortable, it's normal. And it's just kind of like, okay. So I kind of took it upon myself to reach out to another CF patient that I knew had had a transplant, and she's 5 or 6 years post-transplant. She's not around this area, but I kept in contact with her when I got to use my phone and my computer again. I was typing her and messaging her and saying, is this normal? How long does this take? How long is this? And how long is normal? And when should I be doing this? And she was a great kind of resource for that kind of stuff. So I think that having, and I know I've been asked to kind of talk to other CF patients that are on the list or are in the process of going on the list, and I think that's really a great thing, because I don't know what I would have done without, and I met her on Facebook, so it's not like we've actually met in person, but she was great to kind of chat to, and just to know what the normals were, and like know that it was going to be be okay, and I was going to make it through, and it was going to be fine again and normal. Well, my new normal, so.
It's really important information to have. I'd like to open it up to the audience, for people who have questions or thoughts.
How did you find an apartment in Boston?
That's a question for my mother. Lots of hours of looking and asking everybody, any resource in the hospital, the social workers. She gave us pamphlets of information, but mostly it was going around and asking. I know my sister's, one of her friends, knew somebody in the hotel business, and they were able to stay there for a while before we were finding an apartment, and they had, said check here, and then just kind of walking around the neighborhoods and walking in and saying, do you have any apartments available? So yeah, it was a challenge, but.
Because you can't exactly nail down when you're gonna need it. You don't know when you're gonna need it. You kind of just need it now. So that was the tricky part. So for a while we stayed in hotels, but we needed a place for her when she got out that was, cleanly and all that stuff. So while we were staying in hotels, Mom was doing lots of research.
And walking a lot. Lots of walking, up and down. And evaluating if I could make the walk after my transplant, which is probably very hard for somebody that has not had a transplant to evaluate. So very good kudos to Mom for finding a great apartment for us to live in. And many other things.
I guess I'm curious, why don't you have to do airway clearance anymore?
So my lungs do not have CF anymore. I have completely normal lungs, and they're able to, it's like your lungs. I can clear things easily. They don't stick down in there, and yeah. I don't really have a great answer for that, but it's like having somebody without CF's lungs. So like you wouldn't have to do airway clearance if you were sick, because your lungs are completely functional by themselves, and you don't have those extra secretions, and they're not sticking your villi down, so they're kind of just, they're flapping around like they should in there. I don't know if that answered your question. Was that helpful at all?
No, it does. I just remember from our very first CF education, right? This was back down in New Orleans, though. And there was someone who had gone through a transplant that spoke, and they talked about how it's not a cure, that like you still have CF. So I was thinking that the secretions and all would still be there, but I never thought of the lungs as like the lungs don't have CF.
So in many respects, getting a lung transplant is trading one set of problems for a different set of problems. Your chronic illness is still there, but the CF nose is still the CF nose, and that's a problem because the bugs live there. And so getting pneumonia post-lung transplant is a problem, and it's one of the reasons why inhaled antibiotics in a lung that has normal airways work even better than in the CF lung and can keep, from setting up chronic infection in the lung. But there's none of that bronchiectasis, none of that airway dilation. It sometimes can develop if you get complications of rejection of your lung transplant, but up front, it's not there. And so that, I should ask you, I've never asked you this, is that the best part of having a lung transplant, is no more airway clearance?
No, breathing definitely is.
Breathing, okay, fair enough. I should have maybe said some people have said it drops the burden. That's such a burden. Yeah, it's a time-consuming, nobody likes it, it takes forever kind of thing. And so that burden is sort of gone, and you trade it out for a bunch of pills sometimes, which most people, or often would say that's a good trade. But I agree, breathing is way up in front of you.
what are you physically able to do? Are you capable of exercising and running a marathon? Are there any limitations on what you can do versus? I mean,
Whatever I
understand
want, but I do not enjoy running. So I will not be running a marathon, but exercising, hiking, that kind of stuff. Hiking is my dig. I have a dog and we go hiking all the time. My cousins and I, we go hiking all the time. So got lots of pictures from my first year back and able to actually hike. So yeah, whatever I want really.
How about your anti-rejection medications? Side effects, a problem?
Initially, I feel like I had more side effects. Now I just can be shaky sometimes. I don't have problems with it. There's a boatload of problems that you can have, but they're really good at monitoring blood work and everything to find if there's a problem happening, because it's really common to have trouble with your kidneys on some of the medications that I'm on. But you know, they're doing blood work I'm every 3 months now at Boston. For the first year it's every month, and then once you've kind of gotten past that first year, it's about every 3 months. So a lot like CF clinic. So I'm going there every 3 months, and I'm going to CF clinic every 3 months. And they keep really good track of that as far as blood work and finding anything that the medication is affecting, and then being really proactive about treating that.
Can you take a drug like Orkambi to help treat like your sinuses?
I don't believe so, but I'm going to let Dr. Leclair take that one.
Yeah, no, interesting thought, but it's not approved or recommended for patients who have undergone lung transplant. There's, you know, people on Orkambi will sometimes say that their sinuses feel a lot clearer, and I think it, you know, there's potentially benefit there, but it's not indicated for people who have had transplant.
No, this may not be true, but I think I've heard before that people that have had transplants, not just lung, but whatever transplant, are kind of immunosuppressed, so you have to be careful. And if that's true, do you still have to avoid being around other people with cystic fibrosis, or just people that are coughing in general, or?
I mean, I kind of keep it to the rule of how I was with CF, well, in my lungs, because I obviously still have CF. But as far as, you know, I try to avoid the sick people. My sister has CF. I've always been around her. That's never been an issue. So I kind of just treat it because with CF, you're immunosuppressed anyway. And then when you have transplant, it's kind of like she said, trading one for another. So again, you are immunosuppressed with these drugs. However, they have you on a lot of other drugs that, you know, help prevent. So I'm on antibiotics, I'm on anti-fungals, I'm on antivirals, that kind of stuff. That's kind of like the day-to-day medications. So.
Are you both back to work, or were you able to work during your pregnancy, or did you want to? I mean, like, what's your employment type?
So I am an athletic trainer, and I worked the entire time that I was pregnant at Rice, about 30 plus hours a week. I was fortunate to be able to take about 5 months off and then get offered a job that was 5 minutes from my house. So I took that, so I'm now doing athletic training, but doing it at Mount 8 instead of, where I went to high school, instead of 40-minute drive, so I get to be closer to home and be with my daughter more. So yeah.
Yeah, and after transplant, you kind of have restrictions for 3 to 6 months, depending on how your recovery is. I went back. I started covering shifts probably 3 or 4 months after my transplant, but that was just a few hours a week. I'm a veterinary technician, and now I work full time. So.
You know, and I'll say that there was this wonderful transplant doc at the Brigham, Dr. Fulbury, who recently left to go to University of Colorado, and I always loved her perspective, because I would call her and I would say, you know, so-and-so wants to do this or that, you know, and she would sort of sigh sometimes, and then she would say, well, that's why we got him a transplant, you know. So it's you know, the hope is that, you know, everybody wants you to reap the benefits of your good health, and our experience has been that our folks post-transplant can and do work and work full time. The accommodation that a transplant patient needs is the same accommodation that a transplanted patient needs, and that is that when you're sick, and we need to stop and be able to respond to it. You know, and we can all appreciate potentially how hard it is to hit pause on your life that way, but it's got to be there, because if there's some intervention that needs to happen, it needs, you know, it has to be the most important thing. So, you know, I'm always pleased when our patients, transplanted or not transplanted, get an employment where they're a good employee, they're a valuable employee, and their employer respects that and can allow them the freedoms that they need to continue to take really good care of themselves. So, you know, that's something that we're always seeking out and hunting and encouraging folks to go after, because it's important that folks be able to do what they want with their lives, and understandably so, many people need to and want to work, and so that's, you know, it's a huge part of it. And there are some restrictions post-transplant, particularly focused on exposure to infectious things that, you know, could potentially put you at risk. And if you're not transplanted, you know, recurrent respiratory viruses jumped top to my list. So like preschool teachers, those sorts of environments are often not great ones for CF patients. But in general, we're in the business of getting people to be able to do what it is that they want to do. So that has to be out in front of everything else. And the transplant centers generally have that perspective to a point, because they're also very protective of the patient's health as well.
Yeah, I mean, there definitely are some restrictions in my job, just because there are certain animals that carry certain bacteria that I can't work with. Particularly, we have an exotics vet at the animal hospital that I work at, and I have to switch off if he sees a bird or a lizard or anything like that, anything exotic really. And I can't clean litter boxes. So, you know, that's a benefit for me. Everybody understands, and they work with me if I'm in the position of having to do those kind of jobs. So they're really great and super understanding. I've actually been there for 11 years, so they've been with me for the long haul. So they know.
I promise I'm not obsessed with airway clearance, but how did you do airway clearance when you were pregnant?
So for the first 7.5 months-ish, I was still able to wear my vest. I unclipped the bottom clip of it so that it went kind of around my belly, but kind of stayed along my rib cage the way it was supposed to. And then after that, it became a little bit more difficult to have it on. So my husband was great and did CPT. And obviously you have to, I couldn't do the position where I lay on my stomach, but I just lean further forward and he would just hit lower down on my back.
Kate, you said you had met someone on Facebook that had a transplant that you communicated with. Meg, did you do the same thing with someone who's with CF who was pregnant before? Or?
I did not. Unfortunately, I didn't have I wouldn't say the ability, I just didn't have the time to sit down and try to seek somebody out. And as I'm sure a lot of people know in this room, that having CF can be be somewhat isolating sometimes because you're not supposed to just get together and have hangouts. So it's not like you can, just get together with a group of people and talk about your experiences. It's much easier now with social media, but no, I didn't really reach out. I think there was maybe one person that we had tried to connect, and we just didn't have the chance to, never worked out to connect, but no, I didn't. I should have, but I didn't.
Seems like it all worked out.
It did.
Other questions from folks? I did want to come back to you guys, and if you had any final thoughts, if there were something we didn't ask today or didn't get asked, what has been on your mind since being up here and having the willingness and the courage to speak to everyone here about your experiences. If there was anything else that you kind of wanted to say or wanted us to know that we didn't ask about today.
I can't think of anything. That's what you guys are for. Think of anything we didn't cover, and then you ask the questions.
I don't think so.
Well, I think we can end it there, but I did want to say that it's been, an absolute privilege to hear your guys' story today, and thank you for coming to do this.
I'd like to say thank you to Meg and Kate especially, and Dr. Leclair, and for Tara for moderating the discussion. Definitely insightful and interesting, so thank you very much. And thank you all for coming tonight. There's still a few vendors left if you wanted to go visit with them. And thank you for attending, and feel free to email us and join and get on the advisory board or advocate in any way that you'd like. And if you could leave your name tags either on the table or at the table right outside the doors, that'd be great. Thank you very much for coming.